we know that the blood-brain barrier is more leaky in patients with MS than in healthy people, not just where we have the lesions that we can detect on MRI that usually enhance when you give gadolinium, but also in the part of the white matter that appears to be normal. And previously, it's been shown that for people who are undergoing treatment with Fingolimod or Natalizumab, that if you measure the blood-brain barrier permeability at 6 months after treatment initiation, you can predict the 2-year treatment response, specifically whether people retain no evidence of disease activity status or if they experience disease activity. Also, if you have optic neuritis, where you're of high risk of developing MS, about 50% within the next 2 years, we know that the people who go on to develop MS, they also have a higher blood-brain barrier permeability than the people who never, or who don't, develop MS within the next 2 years. What we hypothesize is that it's due to a level of subclinical inflammation, so that there's some sort of subclinical disease activity, which then makes the blood-brain barrier more leaky, simply due to the inflammation that's in the body and the brain. So that it is not the primary mechanism for the disease activity itself, but more an effect of it, and an effect which we can measure. So that if the inflammation goes down, the barrier becomes less leaky. We measured the blood-brain barrier permeability using an MRI scanner in 15 people with relapsing-remitting MS who were about to initiate Alemtuzumab treatment. And we did it by use of what we call dynamic contrast enhanced MRI, where we do the MRI recording whilst we're injecting gadolinium, and we then use tracer kinetic modeling to extract an estimate of the permeability. And we did that scan right before the patients received Alemtuzumab, and then 6, 12, and 18 months after the initial treatment. And what we saw was that and then 2 years after they initiated their treatment, we looked at whether they had experienced any disease activity or not, according to the no evidence of disease activity criteria 3. And what we saw is for the people who did not experience any disease activity within those 2 years, they started out with a rather leaky blood-brain barrier, and then 6 months later, it had become much more tight or non-leaky, whereas the people who went on to have disease activity and who maybe even needed to change treatment, their blood-brain barrier did not become less leaky from baseline to 6 months. So that was, I think, really the recap. So in other words, you could say that we were, on a group level, able to predict the disease activity within 2 years from the change in blood-brain barrier permeability from baseline to 6 months. All right, so the motivation for even doing this study was that we know that the earlier you have a better disease control of relapsing-remitting multiple sclerosis, the less of a risk you have of the patients have of developing lasting disabilities, and also the less of a risk you have of developing progressive MS. So obviously you want to treat as effectively as early as possible, but also in light of the side effects that are with some of the more effective treatments, you don't want to start out too harsh. So if you're able to very early on detect any oncoming disease activity, you will be able to more quickly switch to a more effective treatment. So instead of having to wait 1 or 2 years to actually see the disease activity, if you already after 6 months would know that this activity was not, this treatment was not effective enough, you could change to something that was even more effective. And obviously this was a small study with only 15 participants, but the findings are in line with what we also see regarding the optic neuritis patients and the patients in Fingolimod or Natalizumab treatment. So one could hope that in the future, something like this scan may be used to recommend treatment change or identify patients who are in need of extra surveillance.